Good morning, Jabari. Good morning, everyone. All right, so this morning we're going to be talking about Horner syndrome and light near dissociation. Our objectives are to review the sympathetic and parasympathetic pathways. We're going to talk about Horner syndrome. We're then going to review the light reflex pathway, and we're going to talk about light and near reflex, light and near dissociation, and lesions that can cause light near dissociation. So our sympathetic pathway prepares us for emergencies, and we know that the neurotransmitter is at the postganglionic endings is acetylcholine for the sweat glands, but norepinephrine otherwise. For the parasympathetic pathway, then the main neurotransmitter is acetylcholine. And here you have a cartoon just showing you that your preganglionic neurotransmitter in the sympathetic division is acetylcholine, and at the nerve endings it's norepinephrine, whereas your parasympathetic pre and post ganglionic neurotransmitter is acetylcholine. So for those of you who were here earlier, you had a chance to view the quiz, and we're going to have a look at this quiz at the end of the session. Just a few quick questions just to see where we are before we begin. So anyone can volunteer for the first 4 questions. Do we have any volunteers? Don't all shout at once, guys. All right. So the first question we're going to ask, you don't have to get it right, guys, all right? Hosseini, go ahead. You have your hand up. Go ahead, open your mic and tell us what you think.
Good morning, Doc.
Good morning.
I think the first question is true.
Okay. The sphincter muscle constricts the pupil and is under parasympathetic innervation.
Yes, I agree.
All right. So write that down. We'll check it at the end of the lecture. Anyone else want to volunteer? Or Hussein, you want to go ahead with the second question since it's kind of related?
I also think this is true.
At this point, it doesn't matter. That's all right. That's all right. So, all right. Does anyone else want to take the third question?
Doc, when you say nasal fibers, it's like the ones that take up the temporal vision and goes to the nasal parts. I can't explain them. The nasal retina.
Sorry,
So
could you repeat that, please?
if it's what I'm thinking, then I think the one with the light in the light pathway, I think that is also true.
Okay, you think that's true. Okay.
Yeah.
Good. What about the other one? The other question, number 4.
I have no idea.
All right, that's great. That's a wonderful answer. All right, so we're gonna move on. Thank you for participating. All right, so those of you who came a little earlier should have seen these other questions, which we'll talk about a little later. All right, so the pupil is a central portion of the iris plane, and it can constrict or dilate. So when it constricts, we call that miosis, and that's controlled by the sphincter muscle, which is under parasympathetic innervation. When it dilates, we call it mydriasis, and that's controlled by the dilator muscle, which is under sympathetic innervation. We're going to speak first about the sympathetic pathways, all right? So the sympathetic pathway originates in the posterior lateral region of the hypothalamus. It has first, second, and third order segments. The first order neuron gets certain information from the ipsilateral posterior lateral hypothalamus, and it courses through the brainstem to the intermediolateral gray matter of the spinal cord and terminates at the ciliospinal center of Budge-Waller, which is at the level of C8 to T2. The second or preganglionic neural pathway continues and passes from the ciliospinal center to the superior cervical ganglion in the neck. It exits the spinal cord at T1 and travels cranially, passing under the subclavian artery before traveling over the pulmonary apex of the lung. It passes through the stellate ganglion without synapsin there, and then it goes to the superior cervical ganglion where it synapses, usually at the bifurcation of the common carotid artery at C3 to 4. So here we have a pictorial. So we said the first order neuron starts in the posterior hypothalamus, and it courses to the ciliospinal center of Budge-Waller at C8 to T2. Then second order neurons, it's going to travel from here to the superior cervical ganglion. The third order neurons, or postganglionic fibers, ascend with the internal carotid artery in the plexus and enters the cavernous sinus, where the fibers are going to travel with the sixth cranial nerve. The fibers are going to exit the cavernous sinus and join the ophthalmic branch of the trigeminal nerve and exit the skull via the orbital foramen. The sympathetic fibers are then going to reach the ciliary body and the dilator pupil via the nasociliary nerves and the lung ciliary nerve. So here, just to recap, we have our first order neuron starting in the hypothalamus. Can everyone see the pointer? Starting in the hypothalamus, it's going to course along to the ciliospinal center of Budge at this level here. Interestingly, it's going to go over the pulmonary apex, here's your lung tissue, and under the subclavian. So this is very important before it synapses in the superior cervical ganglion. And then the third order neurons are going to travel along with the internal carotid artery. In the cavernous sinus, it's going to be traveling parallel or alongside the sixth cranial nerve, and then it's going to supply the dilator pupil muscle via the lung ciliary nerve. So we're going to talk about Horner syndrome, which is a deficit along this pathway. So the symptoms of Horner syndrome is usually, some people say a triad, but you will have mild ptosis. And remember last week we spoke about something else that caused profound ptosis. But in Horner syndrome, you're going to be having a very mild ptosis. You're going to have meiosis, which is because of the unopposed action of the pupillae, and that's going to cause anisocoria, where one pupil is large and one pupil is small. That's what we call anisocoria. So it's a difference in the sizes of the pupil. With Horner syndrome, this anisocoria is accentuated in dim light. So the smaller pupil looks smaller in the dark. All right. You also have hyperchromic heterochromia, which means the iris may appear lighter in one eye. When it appears lighter in one eye, the affected eye is the eye with the lighter pupil, and this is usually in congenital Horner syndrome. Another sign is that you may have reduced ipsilateral sweating, and this is if the lesion is below the superior cervical ganglion. But Horner syndrome is usually asymptomatic. So here we have two photographs, an older gentleman on the left, and if you follow the eyelids, you're going to see that this lid is slightly ptotic. Now look at your light reflexes, they're central. All right, so this person is orthophoric. All right, his light reflexes are central. He just has a mild ptosis here. Okay, now this is a child, and if you look, oh, nice big beautiful eyes here, but they're still beautiful over here, but you can see that this lid is a little ptotic. So this is a very mild ptosis. But if you look carefully, the iris here is quite pale compared to the iris here, which is much darker. Again, the light reflex is central. I hope everyone appreciates that and why I'm stressing that because of what we saw last week. So just to recap, very mild ptosis. You have anisocoria. Here you see that this pupil is small. This pupil is a little bit larger, but the reflexes are central. Husseini?
Sorry.
Okay. All right, so what are some of the causes of a Horner syndrome? So for the first order neurons, you may have brainstem disease such as stroke, tumors, or demyelination. You may have a shringomyelia. You may have lateral medullary syndrome, cervical spinal cord lesion, or diabetic autonomic neuropathy. For your second order neuron, you may have a Pancoast tumor. You may have carotid and aortic aneurysm and dissection. You may have a thoracic spinal cord lesion, or you may have other neck lesions. Your postganglionic Horners may be secondary to internal carotid artery dissection, nasopharyngeal tumors, cavernous sinus mass, otitis media, or cluster headaches. So in investigating these patients, usually you're going to refer to a specialist for neurological or neuro-ophthalmological assessment, but an acute presentation is an emergency. They're going to need imaging from the aortic arch, extending from the aortic arch to the circle of Willis, and we're going to treat the underlying cause. We're going to talk about the parasympathetic pathway, but let me just take your register right now. 1 second. So the parasympathetic pathways has three major divisions. You have an afferent division, an interneuron division, and an efferent division. So your afferent division is going to start with your ganglion cells, which are the first neurons in the afferent chains. They're going to give rise to the action potentials. The photoreceptor and your bipolar cells give rise to generator potentials. So the cell axons from the nasal retina, which is your temporal visual field, are going to hemidecusate in the chiasm to the opposite side. So they're going to cross to the opposite side. Whereas your axons from the temporal retina are going to stay on the same side, and they're going to travel in the optic tract. In the interneuron arm, the fibers from the distal optic tract are going to travel to the brachium of the superior colliculus. They're going to synapse in the midbrain with the neurons of the olivary pretectal nucleus, and these represent the interneurons. So here we have our fibers. So we have our temporal fibers here and our nasal fibers here. And as I said, the nasal fibers are going to hemidecussate. The fibers are going to hemidecussate. The nasal fibers are going to cross in the chiasm. The temporal fibers remain uncrossed. And so your crossed fibers from your contralateral eye and your uncrossed fibers from your ipsilateral eye are going to travel together. Now these fibers are going to travel to the pretectal nucleus at the level of the superior colliculus. And from here, these fibers are going to cross again, and some fibers are going to go to each Edinger-Westphal nucleus, which we're going to discuss now. So your neurons of the Edinger-Westphal nucleus are going to send preganglionic axons to the right and left fascicle of the third cranial nerve. They also send preganglionic accommodative fibers. The right and the left fascicles exit the midbrain through the subarachnoid space, and each continues toward the orbital apex. They're going to pass through the cavernous sinus to the orbital apex, and they're going to synapse in the ciliary ganglion. Your postganglionic neurons are going to pass into the eye via the short ciliary nerves, and the nerves are going to innervate the iris sphincter muscle. Now, the ratio of accommodative to pupil fibers are 30:1, so they're much more accommodative fibers than pupillary fibers. And these pupillarins are going to innervate the iris sphincter muscle in a segmented distribution. So we stopped at the Edinger-Westphal nucleus, and here we see the fascicles are going to travel along your efferent pathway to your ciliary ganglion, and then these are going to innervate your constrictors. So when you're in the clinical setting, to observe the light reflex, you're going to have the patient look at something in the distance, and the lighting should be subdued, and you look for a direct pupillary response when a bright light is placed before one eye. So you're going to observe the pupil. It's going to constrict briskly, and then subsequently there's a slow dilatation to an intermediate size. And then you may see some little movements that we call hippus. So that's normal, all right? So the near reflex isn't really a true reflex, and it's activated when the gaze is changed from looking in the distance to a near target. So it has three components: accommodative, convergence, and meiosis, CAM. The final pathways for the near and light reflexes are identical, meaning they go from the third nerve, ciliary ganglion, short ciliary nerves. The center for the near reflexes are in the frontal and occipital lobes. The midbrain is the center for the near reflex. In the midbrain, the center for the near reflex is located more ventrally than the pretectal nucleus. Thus, compressive lesions involving the dorsal internuclear neurons are involved in the light reflex, but they spare the near reflex. All right? So when we talk about light near...
Sorry to interrupt you. Could you repeat that
Yes.
last statement for me, please?
All right. So what we're saying is in the midbrain, the center for the near reflex is located more ventrally. All right? And thus compressive lesions are going to spare the near reflex fibers. All right, that's compressive lesions involving the dorsal neurons. We're going to talk about this a little more. You're going to see a little more. All right. So when we talk about light near dissociation, we're talking about damage to the post-ganglionic parasympathetic axons, such as denervation, which is going to result in an AD's pupil or trauma. The surviving cell bodies within the ciliary ganglion will sprout new axons and grow towards the ciliary body muscle and the iris sphincter after about 8 to 12 weeks. But remember, I said the ratio of accommodative to light reflex cell bodies is 30:1. So then almost all of the new sprouts reaching the iris sphincter muscle will originate from the accommodative cell bodies. So there's aberrant reinnervation of the iris sphincter, and the pupil sectors that were denervated still will not respond to light, but now they will contract in response to activation of the accommodative neurons, and thus producing a light near dissociation of the pupillary reflex. That is, the pupil will constrict to light, but they will not constrict to light, sorry, but they will constrict to near vision. So what are some of the causes? Along the afferent pathway, we may have bilateral central retinal artery or vein occlusions, optic atrophy, marked retinal detachment, anterior ischemic optic neuropathy, branch retinal vein occlusion, or asymmetric primary open angle glaucoma. Along the efferent pathway, we'll have a pretectal syndrome, which is called your dorsal midbrain or Parinord syndrome. You'll have your Argyll-Robinson pupil, your tonic pupils, which may be local, neuropathic, or secondary to AD's pupil. You may have a third nerve palsy, which causes this, and some miscellaneous causes listed there. The lesions affecting the efferent pathway are the lesions that occur after synapsing at the pretectal nucleus. The lesions at the pretectal nucleus, which is the light fibers, enter the dorsal side of the Edinger nucleus. So it spares fibers for the near response that enter the rostral side of the Edinger-Westphal nucleus. So let's look at a pictorial. We said that some of the causes for your light near dissociation may be afferent or efferent. So your afferent pathway is gonna affect bilaterally both eyes, and we said stuff like your central retinal vein occlusion, central retinal artery occlusion, your retinal detachment, etc. Remember, I said your efferent pathway is gonna start at your Edinger-Westphal nucleus. All right. So we have Parinord dorsal midbrain syndrome. You have your Argyll-Robertson pupils, secondary to syphilis. And then we have our third nerve here. So if you have aberrant regeneration of your third nerve, for example, from a third nerve palsy, then you can have light near dissociation. Also, we're going to talk about AD's tonic pupil, which will cause a light near dissociation. So let's talk about Parinord's dorsal midbrain syndrome. This is a vertical gaze palsy. So your vertical eye movements are generated from the vertical gaze center, which lies in the midbrain, dorsal to the red nucleus. And so your impulse pass to the subnuclei of the eye muscles, controlling vertical gaze in both eyes. So cells mediating upwards and downward eye movements are intermingled in the vertical gaze center, which is in the midbrain, dorsal to the red nucleus. So your signs are that the patients, they can't look up, all right? So they have a supranuclear upgaze palsy. They have a defective convergence, And so they have large pupils with light near dissociation. Some of the causes in children include aqueduct stenosis, meningitis, pinealoma. In young adults, it could be demyelination, trauma, or AV malformations. In adults, it could be cerebrovascular accidents or mass lesions. For your Argyll-Robertson syndrome, these lesions affect the pretectal, which are the light fibers that enter the dorsal side of the Edinger-Westphal nucleus, but it spares the fibers for near response that enter the rostral side of the Edinger-Westphal nucleus. So this results in a light near dissociation. The pupils will constrict to accommodate, but they will not react to light. These patients have small, irregular pupils. And this is highly specific for neurosyphilis. And why they have these small pupils, it's secondary to loss of the central inhibition on the Edinger-Westphal, causing tonic constriction. They have denervation sensitivity because of deprivation of the major afferent supply from the pretectal fibers from Edinger-Westphal, causing increased firing of the Edinger-Westphal. So it is constricted. We're going to talk about Adie's tonic pupil, which is a denervation of the post-ganglionic supply to the sphincter pupillae and the ciliary muscle. And this may follow viral illnesses, maybe corona, we don't know. And this is seen in young adults. Usually it is unilateral. So in these young adults, you'll have a large regular pupil. The light reflex is absent or sluggish, but the consensual light reflex is also absent or sluggish. The pupil will respond slowly to near, following which redilatation is slow. They may have an association of an Holmes-Adie syndrome, which is a reduced deep tendon reflexes and autonomic nerve dysfunction. So if you can see in this picture here, you can see that this pupil looks a little bit larger. When you shine the light in the eye, the pupil doesn't really respond to the light. However, the unaffected left eye, when the light is shone in the eye, you do see a brisk constriction of the pupil. So let's go again. So this is the eye in ambient lighting conditions. All right. There's anisocoria, where the right pupil seems larger than the left. When you do a direct response, there's none, all right, for the right eye. However, when the pen torch is shown in the left eye, there's a constriction of the left eye. And this is showing Holmes-Adie syndrome, where there is reduction in your deep tendon reflexes. So just a reminder that once your light is shone here in the eye, then you have your fibers that are going to hemidecussate at the chiasm. All right, so your nasal fibers will decussate, then they're going to go on to your pretectal nucleus at the level of the superior colliculus. Then we're going to give off fibers to both Edinger-Westphal nucleus, which is going to then travel into the fascicle of the third cranial nerve, to the ciliary ganglion, and then to the sphincter pupillae. And for those who were late, we're just recapping. We just recapped the parasympathetic pathway, and the sympathetic pathway is going to start at the level of the hypothalamus. Then the fibers, that's the first order neurons, are going to go down to the cerebrospinal center of Budgewalla, and then the second order neurons are going to go from there. They're going to travel over the pulmonary apex under the subclavian up to the superior cervical ganglion, where they synapse after passing through the stellate ganglion without synapsing. Then they're going to travel in the internal carotid. And in the cavernous sinus, they're going to travel alongside the sixth cranial nerve. And then they're going to travel along the long ciliary nerve to synapse in the constrictor. The dilator pupillary. So now we're going to talk about pharmacological tests. So here we have someone with anisocoria. Everyone see that the right eye, the pupil is much smaller than the left eye. However, we notice that on our Hirschberg test, the eyes are central. So we're not thinking of something else that we discussed last week. We also look and we see that when we examine the lids, it's very mild ptosis here compared to over here. This is a very mild ptosis. In fact, this lid looks a little bit retracted. But let's focus here, this very mild ptosis here. So in your mind, you're thinking, aha, it must be the right eye that may have a Horner syndrome. So we want to know, really, is it a Horner syndrome? And if it's our Horner syndrome, where is it? Is it along the first, second, or third order neurons? And we're going to find out just how we do that now. So we can use cocaine traditionally or aproclonidine to confirm the diagnosis. And then to differentiate whether it's a preganglionic, which is first, second order neuron, from a postganglionic, which is a third order neuron, we're going to use hydroxyamphetamine to differentiate this Horner syndrome. So to confirm whether or not we have a Horner syndrome, we're going to instill cocaine 4% in both eyes. Now the normal pupil will dilate, but the Horner syndrome will not budge. It will still stay small and mused. Why? Cocaine is going to block the reuptake of noradrenaline secreted at the postganglionic nerve endings. Whereas in the normal pupil, the noradrenaline is going to accumulate and cause dilation, further dilation of the normal pupil. So you will see an increase in the anisocoria, but not from the Horner's pupil. The Horner's pupil will stay mused. In Horner syndrome, there's no noradrenaline being secreted, so the cocaine has no effect, right? So the first thing we do is we put cocaine in the eye. And if it has no effect on that small pupil, we confirm that this is indeed a Horner's syndrome. Aproclonidine is a weak alpha 1 and alpha 2 agonist. So if you drop one drop in both eyes and then check the pupil in another 30 to 45 minutes, the Horner pupil will dilate. And this is because the alpha-1 receptors are upregulated in the denervated dilator pupillae. We can also use phenylephrine to do a similar test. Hydroxyamphetamine, however, is a test that we're going to use to differentiate whether we have a preganglionic or a postganglionic Horner pupil. So when you instill hydroxyamphetamine 1% in both eyes, the normal or the preganglionic Horner pupil will dilate, but the postganglionic Horner will not dilate. This is because hydroxyamphetamine potentiates the release of noradrenaline from functioning postganglionic nerve endings. So in a lesion of the third order neurons, there's no release of noradrenaline from the dysfunctional nerve. So the postganglionic Horner pupil will not dilate with hydroxyamphetamine. So let's recap for a minute. It's a lot to take in. So just remember that to confirm the diagnosis, you're going to put cocaine 4% in the eye. The Horner syndrome pupil will not dilate. Then you want to say, is this preganglionic, meaning first and second order neurons, or postganglionic Horner syndrome? All right. And so what you're going to do next, after you do your cocaine test. Oh, good morning, Carlos. We're almost at the end of the lecture. So the next test you're going to use is your hydroxyamphetamine. So in your hydroxyamphetamine test, your preganglionic Horner's pupil will dilate, but your postganglionic Horner's will not dilate. So let's see a pictorial of this. So you have your patient come in, and you notice that the right eye is meiosed. You have a mild ptosis on the right eye. You notice that you have anisocoria because your left pupil is a little bit larger. So you think immediately this may be a Horner syndrome. You're gonna instill your cocaine, and at first your cocaine did not dilate the eye. Then your next step is to instill your hydroxyamphetamine, and wow, the pupil dilates well. So in this case, can anyone hazard a guess as to what happened here? So cocaine test is up top, confirming your Horner's, but your next test is your hydroxyamphetamine, and both pupils are now large. Can anyone guess and tell me what happened here? Where's the lesion?
Preganglionic.
So Chantel, you're saying it's a preganglionic lesion. Why is that?
Because for cocaine, it would block the postganglionic release of noradrenaline, whereas the hydroxyamphetamine would potentiate, as it says, the release from the functioning postganglionic nerve endings. So that's why you'd have a response.
All right, great, thank you. So she's correct. Hydroxyamphetamine potentiates the release of noradrenaline from the postganglionic nerve endings, and in the third order neurons, there's no release of noradrenaline because these nerve endings are dysfunctional. And therefore, if you have a reaction to hydroxyamphetamine, then you can immediately eliminate the third order neurons and say, okay, it's going to be first or second order neurons. So remember, your first order neurons started from your hypothalamus to your cerebrospinal center of Bujwal. And then your second order neurons started from there and end in the superior cervical ganglion. So anywhere along that, if we ask you for differentials, then anywhere along that track, you could give your differential diagnoses. All right, very good. Now, if the pupil, I should say, let's go back. There's something I should tell you guys. I said it before, but let's just remind you. So if you're seeing anisocoria, but you weren't looking closely enough to see the mild ptosis of the lid here, you can, before you do the cocaine test, you can look at the pupils in different lighting conditions. All right? And if the pupil seems larger in the light, then the larger pupil is the problem. If the anisocoria increases in the darkness, that means you're thinking that the smaller pupil just seems really small in the dark, then we know that the smaller pupil is the problem. So you can just remember L for light, larger in the light, so the larger pupil in the light, all right? Now, we talked about Ades tonic pupil, and we said that Ades pupil is going to affect your females, your young females, usually after a viral illness, and this pupil is going to be larger, dilated. So how we test for an Ades tonic pupil is we give them a mild cholinergic agonist in the form of pilocarpine, 0.125%. And when you give this very mild cholinergic agonist, then you'll have constriction of the abnormal pupil. The normal pupil will be unaffected. And this is because with AD's tonic pupil, you have a denervation, hypersensitivity to this mild cholinergic agonist, all right? So this is just a brief summary. So once you see anisocoria, you're going to check in the light and in the dark. And is the anisocoria greater in the light or in the dark? So if it's more anisocoria in the dark, in a dark room, then we're thinking Horner syndrome, all right? Then we're going to do we do our cocaine test, and dilation does not occur with cocaine. So we're going to do hydroxyamphetamine test. If there's dilation with your 1% hydroxyamphetamine, then we can say it's preganglionic or central Horner's. If it doesn't occur with your hydroxyamphetamine, we say it's post-ganglionic Horner syndrome. All right, so what if there's more anisocoria in the light? Then we really examine the pupils closely, and if we see that there are tears along the pupillary borders, then it could be a traumatic damage to the iris. But if it's a round pupil, if it's a round pupil with poor nerve near constriction, and when we do the 0.125 pilocarpine test, it doesn't constrict, then we use stronger pilocarpine. And if it constricts with your strong pilocarpine, then we say it's a third nerve palsy. And if it doesn't constrict, then it could be someone who got their hands on some dilating drops and they want some time off from work, which has occurred in the past. So it could be pharmacologic pupil dilation. But what we're concerned with today really is what happens if we do the 0.125 test with pilocarpine, very weak pilocarpine, and constriction occurs, then we say it's an AD pupil. All right. So if the larger pupil is in the lit room and you give 0.125 pilocarpine and it constricts, we say it's an AD pupil. Did everyone get the pathway that we went through just now? I hope so. All right. So now we're going to go back to our pre-test quiz, and we'll have volunteers, please, because now we should be able to answer some of these questions. Can we have some volunteers, please?
Hi, Doc. I think the first two are true.
You think number one? Read the question first, Melanie.
Okay, the sphincter muscle constricts the pupil and is under parasympathetic innervation. I think that is true. And the dilation muscle dilates the pupil and is under sympathetic innervation. And I also think that that is true.
Yes. You want to continue?
In the right pathway, the nasal fibers defecate in the chiasm, while the temporal fibers do not. I think
What's that answer, Melanie?
I think it's both, but I don't know if I remember it correctly.
Melanie, let's go back and make sure you get this one. Let's go back to that pathway. What do you think now? The blue fibers are your nasal fibers. The red ones are your temporal fibers. And this is your chiasm right here.
That's true.
Yes, it's very true. So you have to remember that. All right. So just your nasal fibers are going to cross over. All right.
Okay.
And remember, you have a similar pathway for your light as well as your pupillar pathway, with just a little bit of a difference. All right. So your vision pathway um, intersects your pupillar pathway up to the lateral geniculate body, when these fibers are going to leave just before the lateral geniculate body and head towards the pretectal nucleus in your superior colliculus. And then they're going to give off fibers to both Eddinga-Westphal nucleus, and then these fibers are going to travel along your third nerve, which explains your light reflexes, which you're going to have why you have your consensual, and why when you shine the light in one eye, both eyes will constrict, right? And that's because of this, what's happening up here. You're going to have that lecture soon, but yes, Melanie, it decussates right here in the chiasm. All right, got it?
Mhm.
All right, Melanie, thank you. All right, can we have another volunteer for the next question?
Yes, Doc. Horner syndrome may be caused by a lung tumor. I believe that's true. The Pancoast tumor.
Okay, Jabari, can you continue with the other question, please?
The near reflex is not a true reflex, but a triad of accommodation, meiosis, and convergence. If I remember correctly, that's true.
Yes, that is true. All right, and just finish us off, Jabari, since you're here. We can go through this. If it's okay if you don't get it right, it's okay. We're learning together, yeah. And it's just your classmates. So let's go.
All right, a large pupil can be caused by iris damage. That's true.
Yes.
Holmes-Addy syndrome. That's what a small pupil. No, large pupil.
Jabari.
Yeah. Oh, sorry. sorry. Right. Pharmacological mydriasis. Yeah, that's true. Palsy. Yeah, that's true. Horner syndrome. Oh.
Horner syndrome.
Oh, true.
Oh, Jabari.
No, I said no beginning.
Jabari. Jabari. All right. I guess.
I'm kind of distracted, but no.
All right, Jabari, we can't be guessing at this time. So remember when we talk about the Horner syndrome, we said we had three main things that happened in the Horner syndrome. You have meiosis, you have anhidrosis, all right, and you have a mild ptosis, Jabari. I am going back just for Jabari, but this is taking quite a little while. All right. So we said you have a meiosis, mild ptosis. Meiosis means the pupil is small. A mild ptosis, you have anisocoria, which is accentuated in dim light. All right. So one pupil is small, the other is large, but it gets worse in dim light. And we said you could also have a lighter color to your iris. You can also have reduced sweating on that side. All right? All right, Jabari?
Yes, Doc. Thank you.
Yeah, man. So remember that you won't forget this now, right? And so if you're showing a picture like this, Jabari, could you please describe what you're seeing for me?
All right, so in the picture on top, the light reflexes seem to be central, appear to be central. There is a difference in the size of the pupil. The right side is a bit smaller than the left. There also appears to be mild ptosis on the right eye. the iris colors are the same. That's nice. If you want to describe the one in bottom too, Doc?
Sure.
All right, so in the picture below, the light reflexes are central. The otherwise standing out, the pupil colors, the iris colors are different. The left eye, the iris is more pale than the right eye. Sorry. On the right side, there appears to be some lid retraction. Well, no, you can't see this clear well. But the left side, there appears to be a mild ptosis.
Okay. And you figure that's a Horner syndrome, yes? And you remember some of the causes we said of Horner syndrome, Jabari? So, hello? Jabari, you still there?
Oh, yes, Doc, sorry.
All right, so remember the causes can be central,
Yeah.
all right, and can be preganglionic, as you correctly said, a pancreas tumor, carotid or aortic aneurysms and dissections, neck lesions, etc. All right, and post-ganglionic lesions may be as listed there. So try and remember. All right.
Doc, thank you.
Thank you too. All right. All right, so we need our next volunteer to open up their mic, and we're going to tackle this question. I'm actually going to stop the recording now because I want you guys to feel free to volunteer. I hope before we do the next question, is everyone okay? Did everyone understand what we went through just now? We're going to do some questions, but I want you guys to be comfortable. So,
Doc? Sorry, Doc. Could you keep the recording going?
yeah, okay, everyone's okay with that? All right, let's go. You're on. Since you're on, please go ahead and tackle this question.
Okay, a 36-year-old man with anisocoria with a large enough pupil, more anisocoria present in the dark than in the light, partial right ptosis, but extraocular movements are full. All of the following statements are okay. The right pupil would dilate poorly after cocaine. I think that's false.
Why? What's wrong with them? Let's go. Let's see. What's wrong with this eye?
What's he has a Horner syndrome. I'm not sure if it's.
So you're saying he does have a Horner syndrome? Is that correct?
Alright, I'm trying to remember the flow chart. Okay, so I have to just be very honest. So I remember the pilocarpine being on the left. Yes. Okay, so the right side. So it would be. Can you go back to the question?
Sure.
Okay. All right, and can I go back to the flow chart?
Sorry, Carlos wants to jump in and help you.
Sure. Right ahead.
But this is Chantel speaking.
Yes, sir.
All right, Chantel, we're still coming back.
Sorry, Doc. It was an error. I was having a glitch.
What, Carol?
Carlos? Oh, it's Carol. Carol? No,
Oh
you're
my
gonna
God.
help. We can't glitch at this time. Can't glitch. Chantel was thinking, wow, how
Right?
lovely.
That's so
How
nice.
lovely. How lovely. So you can't glitch. So tell us, what do you think is happening here, Carol? Let's see if you what do you think is going on with this 36-year-old man?
Mm, well, Doc, all I can see so far is that he's having a problem with his left pupil, that it's excessively dilated.
I'm glad you said that, and this is why we need to iron this thing out right now. 7%. Whoops, it is this. Okay, so I want you to have a think about it. Really, is it the left eye or is it the right eye? I'm gonna give you just a minute for you all to, half a minute for you all to think about it. All right, time's up. So Carol says it's the left eye, whereas Chantel says it's the right eye that's the problem. And this is very good because in the exam, I don't want you to confuse a couple things. No, let's look at this guy. When we look at his right eye, we see that he has a mild ptosis. Is that correct?
Correct.
We don't see a ptosis on the left eye. All right? No. When you look at the right eye, we also notice that the right pupil is smaller than the left, so he has anisocoria. So, and the light reflexes are bang on straight. So, based on our lecture last week, if we had seen a dilated pupil and the pupil was down and out, then we could say that maybe it has a third nerve palsy. All right? All right. So if you're thinking that it's an AV pupil of the left, they told us something very important. More anisocoria is present in the dark than in the light. All right? So we said in the dark, it's a smaller pupil that's the problem. All right? So right away, you're thinking, okay, if it's a smaller pupil, that's the problem because this is worse in the dark. The pupil is small and there's a mild ptosis, then it must be a Horner syndrome. All right? So the first test we want to do, and they tell you the extraocular movements are full. That means he can move his eye up, down, every which way you go. All right? Oh, you use the physician's right. I'm saying ophthalmology, we use things. I see what you're saying, Husseini. All right, in ophthalmology, you'll notice everything's upside down and forwards, backwards. All right, so the right eye here, or in the exam, you don't have to confuse yourself. Just use your pointer and point to the eye you're talking about, all right? So this right eye is the problem. All right, so we say that this person has what then, Chantel? If the right eye is the problem, what's going on?
I would say that it's a possible Horner's.
All right, so what's the first test then that we're gonna do to confirm a Horner syndrome?
Okay.
And what do you expect to happen if it really is a Horner syndrome?
Then it won't occur.
Nothing would happen, right? It would not dilate, all right? So let's go to A. The right pupil would dilate poorly after cocaine installation. Is that true or false?
That's true.
All right. Question B says the presence of a right abduction deficit.
Excuse me, Doc.
Sure, you want to help? You want to help her?
No, I'm actually confused because I know that the anisocoria is more prominent in dark, but I thought they were actually shining light into the pupil because I saw the central light. So I'm
Okay.
confused. Yeah.
So basically, why? All right. So the stem of the question is telling you what has happened in testing. What that light in the pupil is showing you is that the reflexes are central, so that they're showing you here that the pupil is straight bang on. The pupil is not down and out as you'd expect in a third nerve, where you'd see the reflexes. This pupil would be down here, whereas this pupil would be central. They're making sure they cover their bases to tell you that, to show you that the pupils, the eyes are straight. Although, because remember, one of your colleagues immediately gravitated towards this side, thinking that this is the abnormal pupil because it's larger. And remember, in a third nerve palsy we discussed last week, your pupil, if it's pupil involving, your pupil may be dilated. But in a third nerve palsy, the pupil would be down and out. So what this light test is showing you is that the pupils are central. That's all. They couldn't show you the difference in dark and light in this one picture. All right?
Okay, noted.
Yeah. So that's why they told you in the stem of the question. But you're not off the hook. Someone has to help Chantal. So the presence of a right abduction deficit localizes the lesion to the right cavernous sinus. Is it true or false? And explain why.
I think that is true.
Okay, why? I think so too. Why?
Um, as the bifurcation would come after, so it would be for the ipsilateral side that's affected.
Not really. Any other takers? Why you'd have an abduction deficit? Remember I said that the sympathetic fibers travel along with the sixth nerve fibers in the cavernous sinus. All right, so if you have a lesion in the cavernous sinus, it's gonna affect them both because they're best buds in the cavernous sinus. They're right beside each other. All right?
Yeah.
Okay. So your third question is, neither pupil should constrict to pilocarpine 0.125%. True or false?
That would mean that it's a the pilocarpine would indicate whether or not it's preganglionic or not. Right, Doc?
No, I mean that dilute pilocarpine we use for another test. That's the test for
Oh yes, for
Crohn's AD. So that's a trick,
A's
right? That's just to trick you to make sure you know what your tests are.
Okay.
Third nerve palsy, no, would not react to dilute
It
pilocarpine.
would
You have
be
to use a stronger dose of
pharmacologically.
pilocarpine. All
So
right.
you
So
use
in this case,
hydrox.
we said it's Horner syndrome, right? And so the question is trying to trick you to think that maybe if you didn't recognize it's a Horner syndrome and you thought it was the larger pupil, then you would say then, hey, maybe it would react to that. But that's not the case. So 0.125 pilocarpine test has nothing to do with the Horner syndrome, all right? Reduced tendon reflexes is a possible association, not with Horner syndrome, all right? That's a feature of Holmes A, the pupil, and not Horner's syndrome. All right, so we're going to go on to our next question. Thank you so much, ladies. And oh, that was it. And I'm almost sure there was another question. Okay. I think there was another question at the beginning of the lecture, so let's just go back up to that question. When I do that, I will just let you have a look at that to refresh your memories. All right, so this is the last question. So can we have some volunteers? Carlos, were you volunteering? I'm not sure.
No.
All right, it's important that you guys come on time because there's a lot to get through in these lectures, all right? All right, does anyone want to volunteer for this one? No volunteers? All right, so are there any questions for me?
Doctor?
Yes.
I'm sorry, I just wanted to clear up the positioning of which eye is which. You said in ophthalmology is in the reverse. I just wanted to grasp
not
that.
really. So when you're looking at the patient, let's look at a picture here.
Thank you.
So who is this? Who am I speaking to? Carol?
Yes, doctor.
All right, Carol. So you're looking at a patient in front of you. You're looking at this patient in front of you. All right? The patient is in front of you. Which eye is this that the pointer is pointing at?
I would say that that is the patient's. Where's the pointer, doc? Is back. Okay.
Right. Can you see the pointer here?
Yes, it's stopped now. Okay, so I'd say that's the patient's left eye.
Why? Why would you say that? If you stand in the position of the patient, so if you stand in front of your computer now, would that be your
Yes.
left eye? Would that be your left eye?
Oh, if I stand in front of the computer, I see what you're saying. That would be my right eye.
Yeah. Yeah. So and so yeah, I know it seems a little tricky because remember the patient is now like a mirror image, sort of, kind of. So you have to remember the patient. We're talking about the patient, not you. So it may be on your left, but it's the patient's right eye. All right?
Oh, I understand what you're saying now.
That was the question that you asked before. Would it have been Horner syndrome by chance?
Pardon?
The question you had asked just now was the what would it have been Horner syndrome?
The last question that we had on the board. All right, so Melanie is volunteering. Let's go to that question. All right, so read the question, Melanie, and then let's go through it.
Yeah. A 40-year-old man presents with recurrent episodic unilateral temporal headache and periocular pain over 4 weeks lasting up to 1 hour. He has nasal congestion during an attack. He has anaphoria and ptosis on the same side as the pain during an attack. He had a recent MRI of head which was normal. What is the most likely diagnosis? And all I could think of was probably like it sounds like probably Horner's, but then I'm not sure how to differentiate.
Okay, so there are three answers there with Horner syndrome.
Right. So I think my problem is then how do I differentiate? I think that's my problem. If it is
Right.
Horner syndrome, that is. Okay.
So you want to see whether it's preganglionic, central, or or postganglionic Horner syndrome, right?
Yes.
So you'd have to know the causes of your Horner syndrome. All right, so those are the central causes of your Horner syndrome. Preganglionic causes of your Horner syndrome. And postganglionic causes of your Horner syndrome. All right, so the patient presents with headaches, recurrent headaches. All right,
Probably to be postganglionic then.
so Marie is saying, would it be postganglionic because of his headaches? But what kind of headaches is he having? Yes, you're right. It's because of his headaches, but he's having what you call cluster headaches. So it's a unilateral headache with periocular pain lasting up to an hour and it recurs. All right, and he has nasal congestion during the attack. And just during the attack, he has anisocoria and the ptosis. All right.
So it is
That's
postganglionic then.
yes.
Okay.
All right. All
Thank
right.
you.
You're welcome. All right. So, do we have any other questions? Was this helpful to you guys? Did you grasp the concepts that we were trying to say? All right, so I've gotten 4 yeses so far, and we have 26 people in the class. I really should do one. All right, everyone is coming in now. All right, so oh, I've seen the rest now. Okay, all right. Let's see what y'all are saying. All right, so most people are saying yes, they just need to review. And yes, it's a topic that you really need to review. Going forward, I'm going to ask that, okay, well, this is the last of this topic. These topics require quite a bit of thought and looking back on, I should say. But just remember the salient points that I brought out. Even if the slides were busy, I've tried to highlight the salient points for you to remember for your exams. And so some of the things that I stressed last week, we did third nerve palsy. And I remember showing you someone with profound ptosis. All right. And this week I'm saying you have a mild ptosis here. And you look, before you even open your mouth when the picture comes up, or even if you're saying this is a picture of a gentleman and what I'm noticing, what you look first and you look at the lid position, then you look at the pupils, then you look, where's the light? Okay, fine. I'm thinking it's a Horner syndrome. But you have to see that mild ptosis there, right? Because I wouldn't want anyone to see a ptosis down to here, and then you see someone open the eyes and you see the lid down and out, and you're saying, oh, that's a Horner. So you have to really think about what you're saying We spoke about third nerve palsies last week. We spoke about Horner's and AD syndrome this week. So it's easy to confuse things as we saw in one of the questions, and I'm glad we cleared that up, all right? So just have a quick read again of what we discussed, and you should be good, all right? Are there any more questions? Okay, Dale has a question. Go ahead, Dale. Dale, you
Oh,
can
hi.
go.
Hi,
Hi.
Dr. Moore. Doc, I was just, hello?
Yes, I'm hearing you.
Yes, Doc, I just wanted to say that, this morning I was having some connectivity issues. I'm not sure if other students were, but I was wondering if my name was on the register as well.
But I as well, my internet like went for like a little period of time, so I'm not sure if my name was on the list as well.
All right, no worries. So we've had it taken at different times in the presentation, so no worries. You should be there at 1